Now, ulcers associated with the trauma. The first is the traumatic ulcer. It is also known as tuberculosis ulcer, trophic ulcer, neurotrophic ulcer, and Bednar ulcer. Now, remember, what is the etiology of the traumatic ulcer? Mechanical or physical trauma is the most common etiology of the traumatic ulcer. Physical trauma may be from lip biting, cheek biting, ill-fitting denture, any ortho appliance, etc., or any substance abuse like cocaine, formocresol, eugenol, eucalyptus. There could be thermal trauma, that is from hot liquids and food. Now, clinical features and age. It can occur at any age. It may involve any region of mouth, but most common on tongue, buccal fold, gingiva, and palate. Now, remember, a traumatic ulcer may be crater-like, generally the result of repetitive trauma over prolonged period. Now, you can clearly see this large and irregular ulcer due to blunt trauma to the patient. Now, diagnosis. Now, management is the removal of the caustic agent. Persistent ulcer may be treated by giving triamcinolone acetonide or pain relief like dicyclone HCl. Now, next we are going to discuss is Apt of Stomatitis. It is common disease characterized by development of painful, recurrent, solitary or multiple ulceration of the oral mucosa, where the ulcer heals spontaneously and there are no sign of any other disease. They could be minor aphtha, major aphtha, or herpetiform ulcers. Now, minor aphtha are also known as canker sores and they are less than 1 centimeter in the diameter, whereas major aphtha is known as Sutton's disease or periadenitis mucosa necrotica recurrens, and they are more than 1 centimeter in diameter. Remember, the minor aphtha are less than 1 centimeter in diameter, whereas major aphtha are more than 1 centimeter in diameter, whereas herpetiform ulcers are small ulcers which are less than 0.5 centimeter. They are recurrent dozens of small ulcers. Now you can clearly see a figure showing recurrent herpes minor and recurrent aphthous major. Now this minor will be lesser than it will be lesser than 1 centimeter in diameter, whereas major aphtha is more than 1 centimeter in diameter, and it will heal without scar formation, whereas major aphtha will heal with scarring. So MCQ can be asked, major aphtha is Sutton disease, canker sore is minor aphtha. Aphtha that are less than 1 centimeter in diameter are minor or major. They are minor aphtha, and which are more than 1 centimeter diameter, they are major aphtha. The ulcers that heal without scarring is minor aphtha, and that heals with scarring is major aphtha. Now let us discuss the difference between recurrent aphthous ulcer and recurrent intraoral herpes infection. The recurrent aphthous ulcers are located commonly on the freely movable mucosa, that will be lip, buccal mucosa, tongue, mucobuccal fold, and soft palate, whereas the herpes is most common on the tightly bound periosteum like hard palate, gingiva, and alveolar ridge. The aphthous ulcers are initial lesion erythematous macules which undergo central blanching followed by necrosis and ulcerations, whereas intraoral herpes infections that they are multiple small punctate ulcers or 1 mm or less than in diameter. Now, number of lesions are solitary in aphthous ulcer, whereas they are multiple in the herpes. Now, histology, it is non-specific, whereas Herpes infection shows ballooning degeneration with multinucleate giant cells. Prodromal symptoms are absent in aphthous ulcers, which are present in herpetic lesions. Now let us discuss this disease measuring about 5 cm in diameter that is occurring on soft palate. Now identify, yes, it is Sutton's disease, Picotton's disease. Now Sutton's disease is the other name of Sutton's disease is other name of major aphthe, or they are over 1 centimeter in diameter and they heal with scarring. Now the Behcet syndrome. It is the combination of chronic ocular inflammation and orogenital ulceration. So you can clearly see this diffuse erythema surrounding the numerous irregular ulceration of the soft palate. Here oral lesions are similar to the aphthous ulcer that occurs in healthy individuals and demonstrate the same duration and the frequency. The genital lesions occur in 75% of the patient. In 90% of males, the lesion involves the scrotum, whereas in female they are mostly present on vulva, vagina. So most important feature is the pathergy test. So from a diagnostic standpoint, one of the most important skin feature is presence of positive pathergy. So positive pathergy test is for Behcet syndrome. 1 or 2 days after a oblique insertion of 20 gauze or smaller needle under sterile condition, a tuberculin-like skin reaction or skin pustule develops. Ocular involvement occurs in around 70% of the cases and is more frequent in the males. The most common findings are posterior uveitis, conjunctivitis, corneal ulceration. Systemic medications include azathioprine, colchicine, corticosteroids, sulfasalazine, thalidomide, anti-tumor necrosis factor alpha medication could be given. Now suppose a question comes, a patient with conjunctivitis, urethritis, mucocutaneous lesion and arthritis. Identify the disease. One option is Behcet syndrome, other is Hodgkin disease, third is Greenspan disease, fourth Ehlers-Danlos syndrome. So the answer will be Behcet syndrome. Now another question, positive pathergy test is seen in, you can clearly see this pathergy test picture. Now what is pathergy test? It is a neutrophilic vascular reaction that is read by physician at 24 or 28 hours. So it is performed under a sterile condition with insertion of 20 gauge needle or a smaller needle. Now next topic is drug allergy. It is also called drug idiosyncrasy, drug sensitivity, and other name is stomatitis medicamentosa. Stomatitis medicamentosa is other name of drug allergy. Now you can clearly see a picture showing the fixed drug allergy reaction. So it is characterized by inflammation, ulceration, and the vesicle formation. The lymph node may be enlarged. The skin is often erythematous type. So you can clearly see this painful ulceration with irregular margin and usually surrounded by erythematous halo. The drugs that can be involved are aminopyrine, barbiturates, gold, bromide, opiate and morphine. The management could be discontinuation of drug, use of antihistaminic drugs, topical corticosteroids or systemic corticosteroids. Next comes the contact allergy. It is caused by delayed type of hypersensitivity reaction to the topical agent. On the skin it is called dermatitis venitata. On the skin it is referred as dermatitis veninata, and oral lesion it is stomatitis veninata. So question is, other name of stomatitis veninata is, it is contact allergy, and it is caused by what type of hypersensitivity reaction? It is caused by delayed type of hypersensitivity reaction to the topical agent. Now next comes the angioedema. It is also known as angioneuritic edema, quincus edema or giant urticaria. Now quincus edema is other name of angioedema. The most common cause is mast cell degranulation that leads to histamine release and typical clinical alteration, that is IgE mediated hypersensitivity reaction, that can be caused by drug, foods, plants, dust and inhalants that produce mast cell degranulation. Now, unusual pattern of drug reaction that can produce severe form of angioedema that are not mediated by IgE is the type that is associated with the use of drugs like ACE inhibitors. They can be captopril, enalapril or lisinopril. Now, the swelling associated with these drugs do not respond well to antihistamine and was thought to be result of excess bradykinin. Now, angioedema can also result from activation of the complement pathway. So, this may be hereditary or acquired. Now, type 1 comprises 80% of the cases and is by quantitative reduction in the inhibitor that prevents the transformation of C1 to C1 esterase. So without adequate level of C1 esterase inhibitor, C1 esterase cleaves C4 and C2 that results in angioedema. So there is rapid onset of soft non-tender tissue swelling that may be solitary or multiple. So in a question come in your exam, they asked is rapid onset of the soft tissue tender swelling that may be solitary or multiple. Your answer will be angioedema. Clearly see the diffuse upper lip swelling that arose rapidly due to the angioedema. There is soft non-tender swelling on the face that develops rapidly after the dental treatment. So the treatment usually consists of oral antihistamine therapy. Case of angioedema related to the ACE inhibitors are not IgE mediated and often do not respond to antihistamines and corticosteroids. So patient with ACE inhibitor associated angioedema should avoid all the medication in this class of the drugs. Erythema multiforme is a blistering ulcerative mucocutaneous condition. In about 50% of cases, the clinician can find an appropriate precipitating cause, usually a preceding infection like herpes simplex or mycoplasma pneumoniae. Types: erythema multiforme minor or erythema multiforme major. The erythema multiforme minor has a typical target lesion. We will discuss that later on. It has a raised atypical target lesion on skin that are less than 10% with minimal mucosa involvement, and they are present only on the one side, whereas erythema multiforme major has at least two mucosal lesions that are typically involved. Now target lesion is the characteristic feature of the erythema multiforme. So these are known as target or bull's eye lesion. Now what are these? They consist of central bulla. You can clearly see the central bulla or pale clearing area that is surrounded by edema and the band of erythema. It is more common in males than in females, seen frequently in children and young adults. So it has got an acute explosive onset with generalized symptoms like fever, malaise, and it may be asymptomatic in less than 24 hours. So it is characterized by macules, papules, vesicles, bulla appearing in a segmental pattern. The lip is the most prominent involved site, followed by the buccal mucosa, palate, tongue. And now important diagnostic feature is lip lesions with presence of hemorrhagic crusting. Now you can clearly see these lip lesions that are extensive with the presence of hemorrhagic crusting. The spontaneous healing occurs in 3 weeks in minor erythema multiforme and up to 6 weeks in major erythema multiforme. Now the difference between erythema multiforme and herpetic gingival stomatitis. Erythema multiforme younger adults are involved, whereas herpetic gingival stomatitis, small children may be affected. So in erythema multiforme, typical hemorrhagic crusty scales are seen, whereas in herpetic gingivo-stomatitis, aphthous-like ulcers, erythema multiforme, there are skin changes, whereas no skin changes. The cause is hypersensitivity in erythema multiforme, whereas cause in herpes simplex virus in gingivo-stomatitis. Now diagnosis is mainly clinical, and we can see the bull's eye lesion with hemorrhagic crusting of the lip or mycoplasma pneumoniae. We can see positive serology test. Now histopathology, you can see the intracellular edema of the spinous layer of the epithelium and edema of superficial connective tissue that may produce subepidermal vesicles. You can clearly see the inflammatory perivascular inflammatory infiltrate that are seen in erythema multiforme. Now treatment is sportive care, electrolytes, liquid diet should be given, removal of the cause, rehydration can be done, topical anesthetic agents like lidocaine gel, benzocaine lozenges can be given, systemic steroid can be given. Stevens-Johnson syndrome, two terms you have to remember is Stevens-Johnson syndrome and toxic epidermal necrolysis. The other name of toxic epidermal necrolysis is the Lyell's disease. Now if you get an MCQ, other name of toxic epidermal necrolysis is Mark Lyell's disease. Now the difference between Stevens-Johnson syndrome and toxic epidermal necrolysis is the degree of the skin involvement, with the Stevens-Johnson having less than the 10% of body affected by the lesion, whereas in the toxic epidermal necrolysis having more than 30% involvement of the skin. There will be more than 30% involvement of the skin. Now these patients usually have flu-like sign and symptoms that includes fever, malaise, sore throat, headache and loss of appetite. Within a few days, skin lesion begins to develop. But unlike the erythema multiforme, the cutaneous lesion of Stevens-Johnson syndrome and toxic epidermal necrolysis initially appears on the trunk. They will initially appear on the trunk, presenting as erythematous macules that are completely flat as compared to the target lesion of erythematous multiforme. Now within 1 to 14 days there will be sloughing of the skin and flaccid bulla will develop. Now let us see what is this bulla and what is this flaccid sloughing. So you can see a case of toxic epidermolysis necrolysis showing the diffuse bullous skin lesion. This picture is from Neville's. You can clearly see these mark lines are there is a diffuse bulla, and with the extensive involvement there will be sloughing of the skin. So you can clearly see that the desquamation of the foot causing the diffuse sloughing cutaneous lesion. Genital ulcerations are most common in the Stevens-Johnson syndrome, which tends to be more severe than the erythema multiforme major. Now biopsy of this bulla of Stevens-Johnson syndrome or toxic epidermolysis show a blister that is characterized by degenerating necrotic basal keratinocytes. Underlying connective tissue usually has a large chronic inflammatory cells. Now one of the important aspect in managing the Stevens-Johnson and toxic epidermal necrolysis is identifying and immediate discontinuing any drug that may be initiating the condition. Corticosteroids may be avoided in the management of toxic epidermal necrolysis because they can be detrimental.